let's turn to stage 4 disease, lots of our patients. And it's been an interesting practice-changing year, I would say, in advanced non-small cell. With particularly, let's turn to the patients without a driver mutation. We are still testing for this up front and siphoning those patients toward targeted therapies appropriately. But for the patients without a driver mutation, what would you say is your approach for patients with PD-L1 levels of 1 to 49%? Haas, I'll start with you.
I think that's a simple question for me. And for me, the practice is now a combination of chemo plus IO. I think the results of several studies now, whether you have squamous cell histology, whether you have non-squamous histology, a different chemo background, they all seem to suggest that IO plus chemo is superior in terms of response rate, progression-free survival, and overall survival in a number of these studies. So my practice has completely shifted to the use of IO plus chemo in the less than 50% PD-L1 positive patient population.
Okay. Charles?
So let me ask you this. I agree, but if there's a patient who came with a performance status of 2, 1 to 49%, you didn't really think that that patient could get triplet. Would you do pembrolizumab based on?
Yeah, 042.
Based on 042?
I'm open to the idea. I really don't have anything against that. I would also argue that we have 4 randomized phase 3 studies suggesting that IO post-chemo can be quite effective in that patient population also. And we have long-term follow-up and survival data for those 4 randomized phase 3 studies. So the sequential approach, if somebody cannot get the triple therapy up front, is still a viable option. But I agree that 042 gives you an option because there was no detrimental effect compared to chemotherapy if you use single-agent pembrolizumab.
So let's talk about the implications. So you mentioned, I think we all agree that Chemo I-O is a very appealing and appropriate choice for most of these patients, that it didn't add any prohibitive toxicity, just basically what you'd expect superimposing our experience of chemo doublets and single-agent immunotherapy. So no real surprises. And it's really just histology-appropriate chemo. Is it going to be a cis or carbo, usually with us carbo and pemetrexed for the non-squames, and a carbo with a taxane, either paclitaxel or nab-paclitaxel in the squames. So that was Keynote 189 really setting the standard for most of these patients with non-squame, Keynote 407 for the squames. You brought up Keynote 042, which was pembrolizumab versus histology-appropriate doublet for 1% or greater. Right. And it was a positive trial, but it looks like it was really propelled by the high PD-L1 patients.
Absolutely.
And the low PD-L1s diluted the results, just not enough to make it negative. And the results showed that, yes, they were comparable, just not better with pembrolizumab. But that trial did not allow crossover, and only 20% of the patients ever crossed over to what you mentioned appropriately is our clear standard of care before this, that we have very strong evidence that there is a highly significant survival benefit to sequential therapy. To me, this suggests that the 80% who didn't get that got substandard care, at least by our contemporary definition. And that, to me, leads me to think it's not that equivalent. It's equivalent, Pembro did as well as upfront chemo with its hands tied behind its back. It wasn't a fair fight, and sequential is still totally appropriate. So it's not that I think it exonerates us to do it in some circumstances for the patient who abjectly refuses or for whatever reason isn't a candidate. But before this, we have evidence that PS2 patients can and do benefit from chemo doublets even with carbo. So I would just say, how do you frame the Keynote 042 results? Is my interpretation fair?
No, I think it is
I
fair.
completely agree. I would not actually offer Pembro just based on Keynote 042. I think there's compelling data both in terms of overall survival and progression-free survival to be able to offer triplets. And if I would really carefully think about the reasons why I'm not being able to offer a triplet. Is it toxicity? Is it age? Is it convenience? I would really examine what the limitations are before offering IO upfront for that particular 1 to 49% population.
Yeah, I think it's not a fair fight. And that has become something a little bit bothersome. We see this a lot in these randomized phase 3s where a good portion of patients post-progression on an inferior arm don't really get the active drug. And if survival is confounded by all of these factors, which we know they are, then you're right, it is a little bit of an unfair comparison. But the data is what the data is.
Right.
The curves don't show inferiority, they don't show harm.
Right.
So I think, again, it is an option. It's not something that I do in my practice, but.
Yeah, I think that it does raise a bit of the question of, for all the dramatically positive results of the combination arms, how much is it really a test of concurrent versus sequential versus 100% access versus 50% access when you cross over? And yeah, these are fair issues. I think the counterpoint would be, well, at least the only way to be completely confident you're going to give everyone access is to start with that, whether that's real or not. And
right.
It raises the question of whether there are any patients for whom chemo up front without immunotherapy, even if you can do it, you might withhold it. And I would say that maybe for PS2 that would come up, maybe. We don't have the evidence to speak to that. But are there patients where you can see a reason to do it sequentially, even if you have the ability to do it concurrently?
Well, again, it has to do with how you interpret the data. And I'm going to raise this very controversial study, Checkmate 227, which I know it's a favorite of a lot of people to beat up. But I presented the data at ASCO with the PD-L1 negative subpopulation. And the punchline is that the TMB low, defined as less than 10 mutations per megabase, PD-L1 negative patients, whether you added IO to chemo or you gave them IO, PFS was no better than standard chemotherapy alone. Yes, it's a small subset. Yes, the study is not completed. Yes, we're looking at the fraction of the patients that entered the study. All of those caveats are there. But to me, that does seem like we might be able to define biologically a group of patients that, based on two different biomarkers, TMB and PD-L1, don't really benefit from addition of IO up front. So it is possible to say that in that patient population, starting with chemo and perhaps trying IO as a single agent after progression might be a reasonable approach until we figure out a way how to treat that patient population a little bit better. So do I use it in the practice right now? I got to tell you, I get a little bit hesitant when I see a low TMB and negative PD-L1 in the clinic as far as, going full forth with the chemo IO and all of that. And again, it is one of those scenarios where I have a very in-depth discussion with the patient, try to give everybody the benefit of the doubt and sort of say, look, there's some studies that PD-L1 negatives, if you give them chemo IO, yeah, PFS is not better, but response and survival is definitely better. So then becomes one of these discussions with the patient to decide how to proceed with it.
So I think we'll need to delve more into PD-L1, into TMB.
Sure.
A little more. I think that really needs to be fleshed out a little more. But just, I'll say that I've had an occasional patient who is older and with a pattern of disease that's been quite indolent, where I haven't necessarily been enthused to do this, just because if they run into toxicity issues, or even if they respond, you're not sure what they're responding to or having this nonspecific fatigue toxicity from. And I'm not that convinced that there's some additive or synergistic effect here as much as just getting it to them. And so for a patient who may be on the bubble for tolerability and who has a pretty indolent cancer process where I have great confidence that they will get their chance with this and get their chance with the other, I have sometimes selected that patient as it would be perfectly fine to just ensure that they get their opportunity with the chemo and their opportunity with immunotherapy. And so that's been about the only case. Most times I think that concurrent is a compelling way to go. Charu, your thoughts?
So I've not had a patient where I otherwise thought that they could get immunotherapy, where I've reserved immunotherapy for later. I've certainly had patients where I didn't think that immunotherapy was feasible because of other comorbidities or coexisting illnesses or autoimmune conditions, where right off the bat, there is no way I can ever give this patient immunotherapy. I just had a patient in my clinic yesterday who is a heart transplant survivor. I mean, immunotherapy is off the table, right? I mean, I just can never give it to them. So it never even comes into the discussion, and I proceed with chemotherapy. But I've not had a patient where I've sort of, if I'm able to give it, that I've reserved it for later. I've not had that yet.